people understand, they share their own knowledge. The objectives as well. Tools. I hear all are talking about tools. In Benin, clearly we were using tools a bit more for higher level of literacy, which was not the case. So we did have some problems on that one. And at the end, we were trying to change the tools from less words and more pictures, which may be more suitable for this kind of individual at that level. And last thing, is that Paul Bergeron's team should also be able to test these tools to make sure they really are useful for the CHW. They are appropriate. Okay, thank you very much.
The IRC's experience in the use of monitoring data, supervision data to monitor the skills and the performance of community co-workers in countries working at a certain level of scale. IRC started working in iCCM in 2005, and thanks to a grant from the Canadian government, remarkably expanded from 2009 onwards to work in 6 countries that you see: Sierra Leone, Cote d'Ivoire, South Sudan, Ethiopia, Uganda, and Rwanda. And at the highest peak of our expansion, we were supporting a population close to 5 million people through a network of 14,000 community co-workers in hard-to-reach areas in 26 districts. And this is a little bit just for you to have an idea of the scale that we achieved. These are the community co-worker treatments on a monthly basis. Here you have them, these are daily by condition. And over the 9-year period, we delivered 4 million treatments. So the technical team, which I am a member of, spent a large part of the first year after this Canadian grant planning the rollout and helping the country set up systems. And we were expected to measure mortality and also coverage of the appropriate treatment for children under 5 through a household survey at the end of year 3. But of course, you can't just wait till year 3 to see how you're doing. So we really focused on data coming from utilization of services and on quality of care to understand how our program was performing. So the data for utilization of services, as the community co-workers were being deployed, we were getting treatment information coming from the patient registers, and that was giving us an idea of how much of the real need we were able to cover. And for quality, we use information coming from the forms the community co-workers had to fill during the supervision visits. So during these visits, the supervisors were expected to conduct general managerial and support functions like, checking the patient registers, making sure the drugs consumed match the patient registers, sometimes replenishing drugs. But in addition to that, the community co-workers in 6 of those countries were also assessing to some degree the skills and the performance of the community co-workers. So in the 6 countries, the supervisors were tasked to check whether the community co-workers had the skills to assess pneumonia, in this case, counting breathing rates. And in 5 of those countries, the supervisors visited together with the community co-worker a patient recently treated from the patient register and to check whether the child had been managed correctly. So the information that was coming from the supervision forms was really good. We were very happy that this is aggregated data from 4 countries for 2010 that shows that 93% of over 24,000 supervisions conducted, the community co-workers were able to count breathing rates correctly. And we also see that out of the 3,000 visits to children with symptoms of pneumonia, 98% the community co-worker had given the child the right drug for the child's condition and age. But the reality is that when the technical field team went to the field, we visited some of the community health workers, we witnessed some of those supervisions, and it was really more often than not that the community health workers really struggled to assess the respiratory rates, and more often than not that the supervisors didn't really know what they were doing at every stage. And I remember asking the country teams, how does it come that if you have 90% of the community health workers able to come breathing rates correctly, you always end up with those who really cannot? And I won't tell you the answer. You've been really unlucky, that was a really poor one, but it was just too often to believe that that was the case. So what does an NGO do when they have a problem? Training, exactly. So we thought that the problem was training. So we elaborated complex forms and we made sure we had very elaborate instructions jointly with the teams and made sure that all the supervisors were trained on those instructions and they adhered to the instructions when they were conducting supervision forms. And then with the time we looked at data and see, okay, now what happened after all these stress on training? And what we saw, this is data from over 95,000 supervisions, again from the same 4 countries, for a 2-year period. And what we see is that the data that kept coming from the fields, from those 4 country programs for 2 years, was just saying that the community health workers were still just doing great. So with the little success of training, we started to think that perhaps it was not that the community health workers didn't know how to use the forms. Perhaps it's that the community health workers themselves didn't have the skills that we thought they had. So they said, okay, next stage, let's assess whether the peer supervisors have the skills that we think they have. So we just did this in a couple, we measured the capacity of the supervisors to assess pneumonia and other things. I'm just showing you this data in a couple of countries, and this is what we found. We found that 70% of the peer supervisors were able to come within race correctly, 74% knew the general language signs, so we had clearly overestimated their skills. And these supervisors were perhaps not that able to assess performance because in those 4 countries, they didn't have clinical skills. And most of the times they were just slightly more educated than the community health workers themselves. But we tried to look at a country who could give us the answer. And that country is Rwanda. I'm really happy that you gave the presentation, Jennifer. Because in Rwanda you have the community health in charge that is based in a health facility and on a quarterly basis will conduct supervision, and of course we assume that those supervisors are, have more clinical skills. So then we went to look at data from Rwanda, and guess what we found? This is 2-year data from over 50,000 supervisions in the 6 districts of Kabeho, Rwanda, in which we work with Concern World Relief. And we're going to start even having the numbers. I mean, the yellow means the percentage of the community health workers that were able to count breathing rates correctly during supervision visit. So what we saw that the data coming from Rwanda was, our hard sand. The data was saying the same. Overestimation of the skills of the community health workers was a problem in all the countries we were supporting, regardless of the level of education of the supervisors. So, with the scale we were getting, millions of treatments, we were getting millions of treatments. We felt that our efforts to use supervision data to estimate the skills of the community health workers was just not giving us any idea of what was really happening. We were a little bit stuck, and we really need to try different approaches. So we decided to be involved directly. The technical unit decided to be involved in direct observation of community health workers treating a sick child during our technical visits to the field, and then decide whether the community health workers had the skills to provide quality care. So we use systematic random sampling, selecting from a list of all the community health workers in the selected areas. We went to the community health workers village and talked to the mothers and found women who would agree to bring their child to the community health worker pretending to be sick with a case scenario previously prepared with the country teams. And while we were sitting at the community health workers' house, we would watch that interaction. We had in every country 4 to 5 case scenarios that included non-referral cases and included also referral cases, and we conducted this exercise in Ethiopia first, and then in Uganda, and then in South Sudan, and then in Sierra Leone. So the skills we assessed in this interaction between the caregiver and the community health worker were the assessment of the child, the referral, classification, treatment, counseling, and recording. A lot of things recording really need to be, assessed, and because we have high level of illiterate community health workers, we really wanted to look at this. Other skills we assessed outside that interaction between the caregiver and the community health worker were drug management, the ability to count breathing rates, and knowledge of the health points for pneumonia. Performance on the skills required accomplishments of several tasks as per the community health worker training manual. For example, for a community health worker to be considered to have the assessment skill, he would have or she would have had to ask the mother the age of the child, probe for cough, fever, and diarrhea, regardless of the medical break of the mother. Ask for the length of whichever the condition the child had, and ask and look for all the general laboratory signs. If that all was done, then the person would be considered to have the assessment skill. So this is in this graph, you have the results of the aggregating analysis for the 4 countries' data in a SpiderWeb's forum, and the skills that community health workers perform the best were by decreasing order, classification, referral, recording, treatment, assessment, and counseling. But this presentation is not about community health workers' skills to provide quality care. This presentation is about whether supervision data in programmatic conditions at scale is able to give us information about performance of the community health workers. So what we're going to do is, for the sake of this comparison, I'm going to take supervision data. I'm only showing you here the quality of care results for counting breathing rates. And the quality of care assessments tells us that 57% of the community health workers assessed could count breathing rates correctly. Supervision data over 170,000 supervisions over the whole, in all the countries over the whole years, all the years of the program, tells us that 96% of the community health workers could count breathing rates correctly. So we have, finally, the evidence that supervision data was not showing us the picture, and that we shouldn't use data from regular supervision to monitor the skills and performance of CHWs. And beware that I'm saying we shouldn't use supervision data, not that we shouldn't conduct supervisions. So while it is important to understand the limitations of the data from supervision, it is also critical to understand that the importance of supervision in supporting the community health workers' management of drugs and supplies, skills reinforcement, credibility at the community level, and the motivation. So the message I would want you all to take away is that as much as it would make everybody's lives easier, it is unlikely that we can rely on routine data to measure the skills of community health workers. The ARC considers that a good approach to getting this information for programs in the field with limited resources would be to conduct periodic quality of care assessments by observing a sample of community health workers at work. For those of you who are wondering what are those two spoons doing in that picture, the point is that when it comes to measuring quality, we think that less is more. We don't need thousands of supervision data points of questionable validity, compounded with the consistency problems between observers. What we need are few observations conducted in a way to limit the variability among observers with valid tools that are actually measuring what they are expected to measure. And that's it.
About the intervention design and how they try to use a holistic approach in addressing the quality of care issues. I'll speak and provide some preliminary results from the trial and the lessons we've learned. And I'll finish off just by a few slides on how we see how NHEalth can be used in a broader context and health system strengthening and possible expansion beyond just iCCM. So some of the barriers that we've seen in our programs that American sought to implement, and also from the literature, is around to have sustained impact of these programs. There's some critical ingredients that would really be key, like having motivated community health workers who perform well, and often motivation and performance is very much interlinked. It's not only about being technically strong to provide good quality of care, it's also about being motivated to do the job and feeling satisfied in the work. Also, for these programs to be able to operate at scale, there is a critical need of having data from the field to be able to monitor caseload and enable community health workers to always have stock at hand, which otherwise undermines their not only performance but also motivation. So the InScale project started in 2009. It was a project funded by Bill and Melinda Gates Foundation to really help scaling up iCCM with quality in Uganda and Mozambique. And it was added on to our grant that was from the Canadian government, which was implementing iCCM in these areas. So the project was set out to identify best practices when it comes to supervision and motivation, and also identify innovative solutions that could potentially strengthen iCCM implementation at scale, particularly looking at motivation, supported supervision, and performance, with the idea that when these barriers or challenges are addressed, more children would be appropriately treated. So this is the actual intervention, which is part of the bigger project, is a randomized controlled trial which is conducted in Uganda with the village health teams and in Mozambique with the APH, again just equivalent to Settlement. And these two community health worker programs are almost at the extreme of the community health worker spectrum. In Mozambique they have 4 months training, they're paid, and they see both children and adults. And they have quite large catchment populations. Whereas in Uganda, they're only trained for 6 days, they're volunteers, they have 2 community health workers in each village, so they have 250 households or so or families per community health worker. So, and they work only with in transport incentives to community and so on, otherwise completely voluntary decision. So, in the InScale trial, I'm going to talk only about the health intervention. We're also doing a community engagement intervention, but I'm focusing on just one of them. We did a lot of formative research and looking through the literature, doing literature reviews in 12 different areas, and loads of interviews with stakeholders and beneficiaries, and then also kind of iCCM global stakeholders. And what came out very much from the field, even though these two programs in Mozambique and Uganda are very different, the drivers for motivation among these community health workers are practically the same. It doesn't matter if they have salaries or not, but really what drives them in performing and staying in their roles was around 3 principles, where one was around understanding and status, identities and values, so basically being an important person in the village, being someone that the community would look up to, feeling a part of a bigger something, like a bigger organization, like community health worker organization. The second one was around support and supervision, not only support from the supervisor, but also from the community members themselves. And the third pillar was around connectedness, feeling connected both to the community, feeling part of the community, but also to the health system and to the health facilities that they were reporting to. So the mHealth intervention that we came up with and which we designed had different components, where the basic principle was that everyone, all the community health workers we worked with, were given a fairly affordable mobile phone and a solar charger, which was a lamp but that also could charge the mobile phone. We used slightly different phones and softwares in Uganda and Mozambique, but the principles were the same. And there were four main kind of packages or components of the package that were delivered, where one was that the community health worker would send in data on patient seen using the phone and get instant feedback on that data that was submitted, which was personalized. That was very important. It came out in the formative research that any communication had to be personalized to be motivational. So it was mentioning the name of the person, community health worker who had submitted the data, and it had always performance and motivating language in the feedback. The data that came into the server was triggering a response. It was based around a kind of an algorithm we developed so that there were alerts sent to the supervisor on each community health worker's performance, whether it was good or whether it was bad. There were green flags and red flags. So the supervisors would have information on each of the people he was, the community health workers he was supervising, so that that data could be used in the supervision. Then we set up closed user groups whereby we had pretty good deals with the mobile phone operators in the countries to get a package so that each community health worker could call anyone, any peer, CHW or the supervisor. They can talk for free for as long as they want. And that was set up to really encourage more connectivity, not only between teams, but between the health facilities and the community health workers. And then every month, there was an automated monthly SMS sent out with, again, motivational language, personal information, so using